the coolness for movement disorder than I encounter in our life.
And I received one question here for you, Dr. Mariam, and it's about essential tremor. And do unilaterality is a red flag? They say that's the question. Is a unilateral tremor is a red flag for essential tremor?
Okay.
If it is highly suspected in scenario, I don't know what they mean. I mean, if you maybe family history or something, but it's a unilateral when it is only unilateral.
Yes.
So
So in most cases, it is bilateral actually, and it can be asymmetrical. So symmetry is not a requirement. It can start with one side, and later on, usually it go on to involve the other side as well. So I think it's mostly bilateral. However, there are some cases where early on it can be unilateral, and I think our mentors here can add to that
yeah,
as well.
Dr. Sulaiman maybe want to add
It's
something.
very important, this patient, if it's sustained like unilaterality, is to rule out dystonic tremor as well.
Right. So usually it's really a red flag
Yeah,
when it is only
it is a red flag.
unilateral. And that's what I think the classification, the benefit of the new classification is actually is the axis 1 till the clinical features.
Yes.
And you may call it tremor plus, and that's where you go
Exactly.
if this with
Yeah.
time and these things, if it doesn't evolve over 3. Dr. Mishal, you want to add?
Actually, just to comment on one thing regarding the new classifications you mentioned about 80 plus, we need to be very careful about the naming of essential tremor plus syndrome. It's a big question mark. Please don't say essential tremor plus syndrome. Essential tremor, they used to, before they're saying it's only tremor, but actually, if you see a lot of patients with essential tremor, they find that there is some posturing, mild dystonic posturing. So now, as from yesterday, we're trying to say, please don't put the name essential tremor plus syndromes. It's still ongoing. We need more trial data about this. So it's mostly ET. If you find like it's typical asymmetric, bilateral, some head tremor, voice tremor, and there's some dystonic posturing, it will be in the same ET because the cerebellum is the pathway for the ET plus dystonic tremor. Also, the cerebellum is involved. So again, the ET plus is still a misnomer, so we need to wait on it for the time being. Just describe what you see and put things together.
Okay, a question,
Thank
Dr. Mishal, since you are here. So patient is, if the patient not controlled on 160 milligram of Andral per day, I don't know why they did not push, then do you prefer Brimidone and what the dose? So I guess this is one of the parts we couldn't cover, probably the treatment for a patient with essential tremor, but you can say when you switch or when do you prefer Brimidone over Andral over Brimidone?
Okay, so actually, Primidone is good. Let's say for the young patient, you can start Primidone, and the elderly Inderal. You start with I usually for the Inderal, propranolol, you start with the 40 milligram BID, or it's 80 milligram. The dose, which is tremorolytic for Inderal, which is propranolol, is 80 milligram per day, 40 in the morning and 40 in the evening. Okay, so this is the way, but it depends on the patients whether you want to use it like a continuous or intermittent. Depends on the situation, but usually it's 80 milligram per day. But if you want to ask me, will they improve below that dose? Yes, but if you want the best, you start with 80 milligram per day, either the immediate or the long acting. That's for the Inderal. Now, 160 milligram, you can push ahead. You can go up to 240 if you want to go. But if they have side effect, actually adding Primidone, the PP together is an excellent push. Actually, the patient will improve remarkably. And if you want a good cocktail, actually, which I do sometimes for patients with resistant tremor, is adding Primidone, Inderal, and clonazepam, okay, benzo. Remarkable improvement. And even for the kinetic portion, the benzo will improve for the kinetic portion of the tremor. But
you want to maintain mono, just to
yes,
you want to maintain a mono, you will try mono.
Exactly.
You will not go to this unless
unless it is pharmacoresistant. You push. Still, you cannot add more medication. Exactly. For Primidone, the dose incubate, we had the 250 milligram, and again we need to start at a very low dose, even at 25 milligram at night, you know, and then you can increase slowly, but don't start on a higher dose.
Oh, very good. Thank you so much. So are we okay with the, there is also one question here for Dr. Mariam. Is a patient is, if the patient did not treat the essential tremor early, does treatment early will change the pathology of the disease or the prognosis of the disease?
Okay, this is an interesting question. Usually, in milder cases which are not disabling for the patient, usually we can wait and not start the treatment and just follow up the patient and monitor. Usually with time, the tremor may worsen, especially those with late onset essential tremor. It has a bimodal distribution. So those, as we looked in the literature, it has been mentioned that those with later onset may have more or faster progression. So this will eventually require treatment. However, does the symptomatic treatment alter the course of the disease? I think that is the question. I don't think so. It's just symptomatic treatment. And there's still a debate whether this is an entirely neurodegenerative disorder or not. So natural history usually entails progression in most cases, as I think.
Right, regarding whether you treat or you did not
Yes.
treat. It's
So
just,
if the patient is disabled, this will determine whether you need to treat or not.
I got another question here while we are sitting. Are we good there for the new? Good. So if the patient with essential tremors seen in a primary care, well, where shall we refer the patient? Well, I can take this one. Why not? So you can try if you are 100% sure that this is essential tremor. You get a family history, or you don't get a family history. You can start whatever as. You can start either with propranolol if the patient is not diabetic or not bronchial asthma. Sometimes we even use these drugs in a patient with controlled bronchial asthma. So beta blockers, yes, why not? And then one of the drugs that probably is evolving is topiramate. Topiramate has also good evidence in a patient with these things. And maybe also levetiracetam is also one of the drugs that has some evidence, and Neurontin has some evidence. And if you fail all these things, maybe you go to invasive procedures. This patient would focus ultrasound, telemotomy, and these things, or TBS, principle, wherever you work and you have the facilities. Well, I think thank you for Dr. Mariam. Excellent presentation. Thank you, Dr. Sulaiman and Dr. Mishal.